start a lecture, I always do a trigger warning when we talk about mental health stuff, because statistically someone in here has dealt with something that we're going to talk about today. So if this lecture is overwhelming, or you just decide that today is not the day that it is best for you to hear about this stuff, you're welcome to walk out. I am not going to be offended. Shoot me an email, we will give you the information, right? Do y'all have any questions before we get started? Okay. So we are dealing with mental health emergencies. Last semester you learned all the basics of all the disorders and mental health and therapeutic communication and all that good jazz. Now we're looking at emergencies. So if we're looking at Maslow, we're going to have some people today that are going to have some physiological needs. Remember, if your patient's not breathing, we have to fix that before we can make sure that they're safe. If they're not breathing, they can't hurt me, right? So remember physiological needs and then safety needs. All right, trauma-informed care. What is trauma-informed care? Basically, that is the nurse assuming that anyone they are interacting with has a trauma history. We're going to treat everyone like they potentially have a trauma history so that we don't re-traumatize anyone that does. It's safer if we just assume that rather than asking in detail questions of all of the patients that we come in contact with. When would it be appropriate for us to ask those detailed questions about a trauma history? When it's pertinent to the situation, or when we have built that therapeutic rapport. So sometimes we need to ask immediately, hey, are you suicidal? Are you having suicidal thoughts? Sometimes though, if we're looking at something that's happened in the past, it's best if we wait until we've built that therapeutic rapport before we ask those questions. All right, the goal of trauma-informed care is to avoid re-traumatizing. Right, we want to make sure we're emphasizing resilience and strength, and that's going to be kind of a common theme we talk about today. And there's these little things here that trauma-informed care is based on. So it's safety, and it's not just physical safety, it's also psychological safety. So making sure your patient feels safe emotionally and physically. How can we best do that? What makes you feel safe? Safe space. And then ask what I just asked. What makes you feel safe? What do you need to feel safe right now? Right? Especially if you have a patient who you know has been through something traumatic, get their input. That's going to make them feel valued, and it's going to create a psychologically safe space for them. Make sure you introduce yourself and your role in every client interaction. Don't assume that people know who you are and what you do. Use open and non-threatening body posture. Okay, if I'm going, hey, what are you doing today? Versus, hey, it's nice to see you. How are you doing today? Those are two very different things, even though the words aren't that different. So remember, a lot of your communication is nonverbal, not just what you say, but how you say it. Provide anticipatory guidance. What do you think that means?
Let them know what's going to happen before you do it.
Yes, that's exactly right. Let them know every step of the way this is what we're about to do. Make sure they're prepared so that we don't catch anyone off guard. Ask before touching. Protect client privacy. When would we not protect client privacy? Right, if they're a danger to themselves or others. So we never tell a patient what you say to me is going to stay between us, because it might not. If you tell me you're thinking about killing yourself, I have to report that. You tell me you're thinking about killing someone else, I have to report that. Okay, so we do not promise privacy. Provide clear and consistent information on expectations and rules, and that's setting boundaries and limits, right? That's 114 stuff. Boundaries and limits are beneficial and safe for everyone. Use plain language and teach back to make sure your patients understand what you're telling them, and practice universal precaution rather than applying these principles as needed. That means we're doing this for everybody rather than on an as-needed basis. All right, stress response. I put this in here as a review. You can review it on your own. This is not new information, but a lot of people we're talking about in this lecture have stress response, and it's why they're acting the way that they're acting. So if it's been a minute since you looked at stress, go back and review that. And then the resilience zone and self-regulation, right? This is experiencing trauma can cause sympathetic nervous system and parasympathetic nervous system to be dysregulated, leading to hyper or hypoarousal, and we see behaviors that happen kind of in the midst of that, right? We want to teach self-regulation skills to our patients so that when they're getting worked up, they can kind of ground themselves. And one of those is something called grounding. How do we ground people? You think about the 5 senses. That's a really easy and good grounding activity that's recommended. So if you see someone who's getting worked up and they're getting more anxious, hey, tell me 5 things that you see. Tell me 4 things you can touch. Right? What are 3 things that you can hear? What can you smell? What do you taste? So focusing them on something that's right in front of them to kind of regulate their nervous system. This also works really well with your ADHD kiddos who are starting to spiral. All right, let's talk about our exemplars. The first one is violence. This is just a review slide. You learned about abuse and neglect last semester in 114. So this is just kind of a review. We're not talking necessarily about abuse and neglect, but these concepts are closely related. So you could see some things that refer to that on your HESI. Remember, there are multiple types of abuse. Who are we mandatory reporters for? Children and? Elderly and?
The mentally
Protected adults, yes. Could be mentally disabled. It could be someone who's physically disabled and unable to care for themselves. So protected individuals, children, and elderly. What about a completely functional 24-year-old who has intimate partner violence? Are we mandatory reporters for them? No. Okay. So competent adults can report if they want to. Now, does that mean that we're not going to involve social work? No. If you have someone who's a victim of abuse, even if they're not telling you that they're a victim of abuse, we're going to tell people in the hospital, we're going to get social work involved. But we're not going to call the police or DHR if it's a competent adult. They get to make that decision. All right. Risk factors for the victim are special needs, people with mental health disorders. Pregnancy is a big risk factor. Not only for starting violence, but also increasing violence. So we see worse violence during pregnancy. And then lack of self-confidence or feeling trapped. My risk factors for abusers are those who use alcohol or substance, those with a history of being the victim of abuse, and those who also have a mental health disorder. Signs and symptoms are going to vary based on the abuse. What would we expect to see for someone with physical abuse?
Bruising.
Bruising in what?
Hidden places.
stages.
Differing stages of bruising, yes. Could be also weird or abnormal places, or bruising that looks like something, a bruise in the shape of an imprint or in the shape of an object. What else might we see?
Burns or
Yeah, burns that look like an object, or immersion burns if you have they stop at a certain point. You can also have fractures that didn't heal very well because they may not have sought medical care, or spiral fractures from twisting an arm. That's a pretty big sign of abuse. You can also see injuries that are not consistent with whatever the storyteller says they are. Right, so my 4-month-old was crawling around and fell down the stairs. Is that a likely story? When do babies start to crawl?
6 months.
Not at 4 months. Okay, so that's pretty consistent. All right, emotional abuse, what is that? Yeah, it can be. So making someone feel really bad about themselves, right? Decreasing their self-esteem, telling them they're not worth anything. It's a way to control people, So making them feel like they can't get out, they can't do better. That is emotional abuse. Sexual abuse, we're gonna talk about a little bit later when we talk about rape. What is financial abuse?
Controlling their money.
Controlling their money. So who would we see that with?
Elderly.
More with the elderly. All right, and then neglect is gonna be someone who's supposed to be taking care of someone is not taking care of them. So if we have an elderly patient who is a victim of neglect, what might we see?
Pressure.
Yeah, pressure sores,
Malnutrition.
malnutrition, dirty clothes, right? And kiddos, what might we see?
Dirty clothes, malnutrition,
Uh-huh.
lack of education.
Yes, all of those things. All right. Questions on the types of abuse? Okay. All right, assessment considerations. When we are looking at someone with violence, so they may have came in and had something violent happen to them, or we may be seeing this on the unit. We wanna make sure we're asking safe questions. So talk about their stress and safety. Are they afraid, or have they been abused? What friends and family do they have that we can call and help them? And what's their emergency plan? And an emergency plan should include somewhere that they can go that is safe and someone that they can call to help get them there. All right, cycle of abuse, the tension building, the acute battery, and the honeymoon. This is with intimate partner violence mainly. All right, and this is a cycle. So we start with tension building, things are kind of ramping up, something happens and there is physical violence. And then after that is, I'm sorry, I didn't mean to, here are some gifts and flowers, and everything is hunky-dory until the cycle repeats itself. And it is a cycle, and it typically repeats again and again and again. Why do patients not leave abusive situations?
It's dangerous to leave.
It's dangerous to leave, absolutely. So us telling them that it's not dangerous, you're gonna be fine, we don't know that, right? There's an increased risk of injury to the patient whenever they try to leave an abusive situation, right? There's also other factors involved. There may be emotional abuse as well, probably is, where they think that they can't do anything, they are not capable of leaving. There may also be financial burdens where they don't have their own money. The abuser may be controlling all of that, and they don't have the means to go, right? What kind of resources do we have in this area? Not a lot, that's exactly right. Okay, so we do have a domestic violence intervention center, and they'll do as much as they can, but we're a poor state, and we don't have a lot of resources. So it's a very unfortunate situation a lot of times that people can find themselves in if they're victims of abuse. All right, vulnerable populations, who would that be?
Pregnant women?
Pregnant women, those people we talked about before, right? Those with mental illnesses or disorders. Children and elderly are abused more frequently. All right, cultural considerations. What cultural considerations might we have with this?
Hitting on women may be acceptable in some cultures.
That's exactly right. So this may be viewed as an okay practice and just fine in some cultures. How would we combat that? Can we combat that? How do you deal with that?
Try to explain it's illegal here and it's not acceptable in this country.
So if you do that to the person who is abusing the female, what might you have done?
Creating worse.
I would do the person doing the abuse.
Yeah, so we want to provide resources to the person. Let her know that there is, or him, it's not always just females. Let them know that there is help available. Make sure that they have resources. Whenever we hand them resources, what we're not gonna do is hand them a card that says Domestic Violence Intervention Center or Domestic Violence Hotline, because if the abuser finds that, then we may have given them another reason to be abusive. So we wanna be very covert with it. Hey, here's a card for a plumber. Okay, and you write that number on there so that they know what it is, but no one else who finds it will. Also, have you guys ever been on, let me just pull it up so I can figure out, where did the X go? So if we were to go to the domestic violence click on it, it's gonna pop up, hey, someone may be able to view your history on here. Make sure that you are safe. And I think that that's really cool, so just wanted to point that out. So we also want to make sure that whatever we're giving patients is not gonna be traceable, because it could be dangerous if it's found by the wrong person. All right, stereotyping. Make sure that we're not using stereotypes. Again, men can be abused just as well as women can be abused. So it happens in the rich, it happens to the poor. There's not one type of person that this is going to happen to. So make sure that we are assessing everyone and not just thinking that because this is a well-to-do white male, they're not at risk for abuse. Mandated reporting, we already talked about that. Y'all have any questions about mandated reporting? Okay. All right, nursing interventions for child and elder abuse, make sure we ensure safety. We want to interview the person that we suspect is being abused alone, and that can get really tricky, especially if you have parents that refuse to leave a kiddo alone, so you may need to involve other team members to help you get that kiddo alone. We're gonna follow state and facility guidelines for reporting abuse. You're never gonna be tested on guidelines that are specific to a facility, but what you would need to know is, hey, no matter what state you're in, you gotta report child abuse and you gotta report elder abuse. Maintain confidentiality, right? That means we're not gonna say, hey, so-and-so is right here, you can come on back. We're gonna be very confidential about where our patients are to make sure that we maintain their safety. Document and treat injuries. We want to take pictures. Okay, we want to document exactly what our patient says. We don't want to infer anything. We use lots of quotes. Document exactly what you see. Involve child protective services or adult protective services, depending on if it is a child or an elderly person. Collaborate care with your social worker and psychiatrist or therapist as needed. Everyone needs therapy. 100% of your mental health patients need therapy. All of us need therapy. So we're gonna recommend therapy and provide resources for those caring for elders, because what do we often see elder abuse as a result of?
Lack of knowledge.
Lack of what?
Knowledge.
Lack of knowledge, lack of time, burnout, stress, right? You've got people who may be caring for children and elderly patients and are working a full-time job. So resources to help meet them where they are. Questions? All right, intimate partner violence. We kind of talked about this one already as well. We can have intimate partner violence. That just means violence in a relationship. Okay, it is very common. Nearly 1 in 5 women and about 1 in 7 men have reported experiencing severe physical violence from an intimate partner in their lifetime. It can be physical, emotional, sexual, or financial. Right, questions about intimate partner violence? We talked about this one a good bit already. What are your priorities? Safety, yes. Are we mandated reporters for intimate partner violence? Not if they're a competent adult, right? Unless they are elderly. All right, teen dating violence. This is a big topic because teens often don't know what they're getting into and they don't know what healthy relationship looks like. Okay, so our biggest intervention here is education. So letting teens know what is a healthy relationship and what is an unhealthy relationship. Also, if we think about Erickson, who has the biggest influence on teens?
Other teams.
Other teens, yeah. So this could get real dangerous and real serious based on where they are developmentally and just their lack of knowledge of the world. So we want to make sure that we are doing really good education with our teens. And again, letting them know what's healthy and what's not healthy. Interventions would be education, and we want them to be able to report anything that's unhealthy. They also tend to think that they are not vulnerable, right? That they are invincible, that nothing bad will happen to them. So teaching them things about how to be safe online, how we don't just meet a stranger on the internet and go meet them in person, those things. Questions about teen dating violence. All right, intimate partner violence do's and don'ts, and this is for both your adults and your teenagers. Don't tell the victim what to do. Remember, we don't give advice. We communicate with our patients therapeutically. We allow them to come to their own assumption of what they need to do, right? We can't tell them what to do. We can't guarantee their safety, and we don't know their whole situation or what they're in. They have to make those decisions. We don't express disgust or anger. That's not our job. We are not judgmental. We don't direct the victim to leave the relationship. Again, that's not our call. We don't minimize. So even if we don't think it's a big deal, if it's a big deal to the patient, it's a big deal. We don't imply the victim is responsible, because they're not. We don't recommend couples counseling. Again, if someone is violent, then couples counseling is probably not gonna be the best option. We want to keep our patients safe. Right? Things that we will do is make sure we believe the victim. We're gonna maintain confidentiality and privacy. The exception of that would be if there was a threat to themselves or someone else. But let's also take a minute and talk about if you have intimate partner violence in the home with kiddos. Let's say that one spouse is physically abusive to the other spouse and they are doing that in front of the kiddos. We are not mandated reporters for the competent adult. What about those kiddos that are witnessing the violence though? Yes, we do lots of DHR reports on the unit for that exact thing. There's kids in the home that have witnessed violence, or that there may be violence being done to them while this is happening. So always think about, are there kids at home in that environment as well? Even though we don't have to report on the adults, we may need to do a report for whatever's going on with the kids. Right, we're gonna listen and affirm feelings. We're gonna express concern, recommend support groups and local outreach and therapy. Remember, everyone needs therapy. Encourage the victim to have a safety plan, and what did I tell you need to be included in that safety plan?
Safe place and then safe people.
Safe place, safe people. Accept the victim's decision, and then offer to contact shelters and authorities for them if they want. All right, we're going to ensure safety, document and treat injuries, and again, we're gonna take pictures, and we are going to document exactly what our patient says. We're not gonna say, husband stabbed patient in the right rib, right? Because we don't know what happened. We're gonna document how long the wound is, what it looks like. We'll check the depth. We're gonna take pictures of it, but we're not gonna assume what happened.
Patient states.
Patient states, yes. Lots of quotes and what patient said, not patient was abused and these injuries happened, because we weren't there. Involve social work or a victim advocate. Provide community resources, offer to contact the police, but again, they are welcome to decline if they want to. Discuss the need for a safety plan. Safety plan's been in here a lot. And then here are some resources, and this is actually the website that I pulled up, and this is the phone number for that. All right, preventing. How do we prevent intimate partner violence? Well, a lot of it is education. That's how we prevent a lot of things, right? So teach safe and healthy relationship skills, and we're gonna start that back in teens. So we can avoid that teen dating violence, and we can avoid that evolving into intimate partner violence when they're older. Engage influential adults and peers to show them what healthy relationships look like. And we also just want kiddos to be able to connect with healthy role models. Disrupt the developmental pathways towards partner violence. So this is gonna be our early childhood home visitation. That's gonna be anyone who we're concerned about, those people we talked about on the unit who are, physically violent in front of kids. We need to intervene there. Preschool enrichment with family engagement. The more we can get families involved, the better off this goes. Parenting skills and family relationship programs, and then treatment for at-risk children, youth, How many programs do you think we have for treatment of at-risk children, youth, and families? Not a lot, so we do have some, but resources are scarce. So we're gonna do the best we can with what we have, but we live in a poor state. And we see this often on the unit. Have you guys been on the adolescent side? Okay, what do we see on the adolescent side when we look at their support systems and home life?
It's terrible.
It's terrible, right? It's very possible to be on that side and have a stable home life, but it's not the norm that we see. There's lots of abuse over there. And then what do we see coming out in the kiddos? What behaviors do we see? We see violence, right? They see violence, now we see violence from them. So ideally, we want to intervene, get that fixed before we end up with a violent adult or someone with a personality disorder as an adult. All right, but we're only seeing a snapshot of it, and we're having a really hard time providing resources for the snapshot that we see just on the mental health unit. So this is a real struggle in our communities. All right, we want to create protective environments, strengthen economic supports for families, and then support survivors to increase safety and lessen harms. Again, victim-centered services, this is all those programs we would love to have, but unfortunately in Alabama, we are severely lacking. All right, questions about intimate partner violence. Priority is safety. When you get someone, we're gonna make sure we assess wounds and treat them first. Remember, we have to have physiological safety before we get to safety. Right, we wanna document using objective things, not subjective. We're not gonna infer anything. We're gonna document just what we see, just what our patient says. Take pictures. Make sure that we're aware of those warning signs of abuse, like bruises in differing stage of healing, right? Fractures that are old and didn't heal very well, injuries that don't match up to the story or that are developmentally inappropriate. We're gonna make sure we provide safety for our patient. We provide resources, but we don't give them advice. They get to make those decisions. All right, I wanna take a 10-minute break because